Good morning, PT on Ice Daily Show. How's it going? The PT on Ice Daily Show is brought to you by the Institute of Clinical Excellence. And while YouTube is going strong, I do not think have gone live on Instagram. So just give me a hot second. Here we go. It is checking the connection on Instagram. All right, we are live on both fronts. What's up? Happy February 1st, PT on Ice Daily Show. I'm Dr. Lindsay Huey, lead faculty for extremity management. Welcome to Clinical Tuesday, my favorite day of the week, to be jamming out with you all and spending some time. So today we are going to discuss getting a grip on lateral epicondylgia care and what that means. So I'm going to unpack three things for you. The basics of treating this condition in a fitness forward way, how our treatment approach focus will change based on the patient's irritability. And then finally, that third thing is how energy storage and release training for the elbow, wrist, and hand is a must in the final stages of rehab for this condition. So, a few things to unpack. Before I dive into that topic, though, on this Clinical Tuesday, I want to share with you that Mark and I pretty much the last couple of weeks that I've been popping on here, we're just so excited for 2022. We'll be traveling again starting in February, and we have a host of courses that we would love you to dive into. So if you check out ptonice.com, go to our courses, and then click on live courses and go directly to extremity management. You will find just a list. We are all over the country, and we are adding in more courses too. So if you are even interested in hosting a course, we'd love to come to you. Each week that I've been on here, you've heard me kind of shout out that Bradenton Beach course. I'm really still excited about it because it's along the beach, and I'll have Melissa Reed be in her clinic. And also she's going to be teaching with me a little bit. So for those that know Melissa, she's a rock star flow master at CrossFit. So it's going to be really cool to have her expertise there with us as well. So please check out that April course. So let's get to the topic at hand. So let's just orient ourselves, as always, when we're talking about a condition, to lateral epicondylgia, right? That name specifically, algia, is purposeful, right? We used to say lateral epicondylitis, but it's a tendon loading issue. It is not an itis issue. We commonly hear it in layman's terms as tennis elbow. And so you'll hear patients commonly refer to that, and even docs, right? When that might be what's written on the script. Final swig of the coffee before I talk more. So these humans are coming to us, and it's because they've either had a recent spike in load to that lateral extensor group, and or they just have a job that requires a lot of repetitive action. So they have this long chronic workload. And so they're coming to you and they are in pain, and everything associated with gripping is super painful for them. In addition, they are having tenderness to palpation at that lateral epicondylgia. It's usually that extensor carpi radialis brevis that's involved, and what most of us just call that common extensor group, where they all connect. And they're going to have pain associated with wrist extension. If you're doing some provocative tests, Mills and Cozen's will be positive. But really, the two main things are they're going to have tenderness to palpation and then pain with manual muscle testing when you look and examine these folks. The basics of treating this condition in a fitness forward way really involve not only treating the tissue locally, but we need to treat globally. And that involves treating the whole shoulder, elbow, wrist, hand. So when you come to an extremity management course, we kind of dive into those basics and the why behind them, but I'm going to list them all for you now. So for local exercise, we're really going to go after wrist extension, right? We're going to do some heavy slow there, whether it's concentric, eccentric or isometric, and that will depend on our irritability, which we'll get into in a bit. We're also going to have some active supination because that supinator is often a problem source as well. We'll be going after eccentric pronation. And then when we're thinking about restoration of global function, there better be loaded carries and then the bent over row. And we really, Mark and I dive deep in our course, Mark Gallant, our other lead faculty for extremity management, about how and why we do each one of those. But these basics, and again, I'm going to repeat them for you, need to be in your repertoire of care when you're rehabbing lateral epicondylgia. Again, wrist extension, active supination, eccentric pronation, loaded carries, and bent over row. That's a little teaser for you to come to our course in 2022. But today, I want to spend most of the chunk of time talking about how we'll manage and use those basics when we're managing irritability in this condition, because no two humans are alike, we know, and we can have this base recipe, but irritability is going to look different on every human we evaluate and treat. So I want to suggest kind of a schematic to think about of some go-to treatments that should be on board when someone's high versus mod versus low irritability. So when we think about high, we think about someone that has high severity. All ADLs hurt. They're impaired in their gripping. They're starting to not do things at work. And then in regards to irritability, high pain levels with a quick ramp up, and then they'll linger for a really long time. So these patients, they really need you to go after modulating their symptoms and their ecosystem. So even though this is a tendon load issue, if you throw tons of heavy loads in the beginning, they're not going to want to come back. So this is really going to involve a lot of education on 24-hour monitoring, the importance of cardiorespiratory fitness to help with inflammation, talking about diet and sleep and hydration. We're going to be behavior modification heavy here. So, what I mean by that, whatever job or sport that's bothering that human, that patient, you have to modify here and decrease the volume of aggravating activities. So, you have to find a way to deload that tendon. And so a simple example of that is the person that complains of like pain with elbow extended and then wrist and elbow pronated. So if that's the position that's aggravating, showing them how maybe they could lift objects with a more flexed elbow and supinated position. So depending on what that activity is or ergonomic setup that's going on that's bothering them, you need to intervene heavy in modification here. The other thing for that person with high irritability and high severity, I'll group in there as well, is that they often have a mechanosensitivity throughout that forearm, right? It's not always local. They're the person that's like, it hurts here and everywhere. And so there's some impaired pain processing on board. And these humans are really going to benefit not only from some soft tissue techniques, whether it's cupping, dry needling, and or massage like pin and stretch, but also radial nerve glides, which really help with the mechanical interface, meaning it helps promote blood flow and activation in that lateral extensor group. So radial nerves are something that I commonly will use in those with high irritability, just to get things moving and to dampen irritability and mechanosensitivity. For some of these patients that maybe have some concomitant range of motion deficits because of guarding in their soft tissue, sometimes they are going to need also some wrist elbow mobilization. This in regards to treating local tendon, because it is important to start some load on the tendon that's controlled, we're going to use isometrics. And here, we don't have a lot of evidence in regards to our dosage. And so Brooke K. Combs, so Coombes, is someone you'll want to look up if you're treating this patient population a lot, and or if you're the patient for those training for the open coming up, which I assume is all of my listeners here today, getting ready for the open that's in 30 days or less. Um, Look up her name because she is a great resource here. And one of her articles looked at an isometric dosage of doing 10 second, excuse me, 10 by 15. So she would do 10-second hold, 15 reps. And that dosage, when we compare it to a lot of our lower extremity literature, is a lot less. So in our lower extremity literature for isometrics, the dosage is 45-second hold times 5. So we're looking at 150 seconds versus 225 seconds of load. And so something to consider that I think we still haven't fine-tuned our dosage in the upper extremity. And yes, I know the upper extremity doesn't it's not as big, right, as our quad when we're thinking about where the studies were done in the lower extremity. But this is a place where I think we can do better. And so I'm not purposely going to leave out kind of dosages today and give you all that autonomy to address those with your patients. But no, we're kind of still searching for that sweet spot. But isometrics to help control pain for so hypoalgesia, not only in the short term, but we see isometrics helping for longer when we use them. So high irritability, that concludes that bucket. So lots of activity mod, radial nerve glides, some soft tissue techniques, and isometrics, possibly wrist elbow mobilization. Moving into that moderate irritability, this is a person that has a little bit longer ramp up time of pain onset with aggravating activities. And it's not going to linger as long as that high irritability presentation. This patient that comes in is still going to have some problems with ADLs, but they're doing most of their functional things. They still need some education, right? They need to know what 24-hour monitoring looks like, how much load is too much, and what signs indicate that we've overdosed and or underdosed. That's an important conversation to have in this moderate irritability because there's this opportunity for them if they do too much to spike up and get to a high irritability stage. And we really want to move them to that low irritability stage in care. So this person also needs a little bit of education on a holistic approach to healing, which is diet, cardio, hydration, sleep, and a little bit of behavior modification, right? We want to keep them moving, deload the tendon a little bit, but have them doing things that are important in their world, whether it's job or sports specific. This is an area where I'm still going to use some radial nerve glides to just help again with that mechanical interface along that lateral extensor group to help with blood flow, nutrition, excitability, all things that are necessary to healing. We'll do some soft tissue. Again, cupping, dry needling, massage are all very important in this region to that extensor carpi radialis brevis, supinator, and even I'll even move into the triceps, biceps at times as well. This is a group when we're thinking about treating locally that we want to get into that heavy, slow, eccentric. So we have the opportunity to start working on some eccentrics where we're restoring length and strength. And this saves us a lot of time in the clinic going after eccentrics versus just static stretching. And you'll see a lot, and I know early in my PT career, I was doing a lot of stretching in this population. And really, they just needed a sweet spot, low dosage. And so I'll challenge you all to, when they're in that mod, to get after the eccentrics as quickly as you can. So that concludes our moderate irritability management of those with lateral epicondylgia. Not so different from high, but we are getting after local tendon issues a little bit more aggressively in the mod, not doing that isometric. Rather, we're going heavy, slow eccentrics, and if we can, some concentric work as well. As irritability, though, dampens, right? You either get to that low irritability stage and or you're lucky enough that the patient is coming to you in that low irritability stage. And so what I mean by that briefly is that it's that person that their pain quickly settles. Even if it spikes up pretty high, it'll go away in 30 seconds or less, or a couple minutes. That's that person that fits in this lower irritability management. Most of their, in regards to severity, most of their ADLs are okay. They're living life and doing their sport and or working, but it's there. It bothers them, and they're kind of just pushing through. Again, 24-hour monitoring needs to be a part of your education. And if for those that aren't as familiar with what that looks like, join me in 2 weeks when we talk about 24-hour monitoring, how that's an all access pass to autonomy for the patient. So 24-hour monitoring, and then maybe some activity mod, right? If you're treating a CrossFit athlete and or Olympic lifter, and there's one lift that just keeps spiking them up and it's lingering for more than a couple days, that's an activity I might modify. But otherwise, I'm keeping them in their activities and trying to give them strategies to help reduce the soft tissue irritability. But this is a group that will have me treating those eccentrics right away. So we're going right after heavy, slow eccentrics. And again, to us, go after that strength and length. I might do some soft tissue work, dry needling for activation, and then just to get that tissue relaxed. And if you can't dry needle in your state, do some kind of pin and stretch and or cupping to kind of offload that tissue. But really, they just need to get stronger and more resilient when they're in this low irritability stage. But the other part that's so key in this low irritability stage, and every patient you see is going to get there, right? Our goal is to modulate symptoms to maximize fitness. You'll probably hear me say that every time I'm on here. And those patients that start at high irritability, we really want to dampen that and increase margin, increase activity and function. And so every human is going to get to this place that you see, whether it's the start of care or towards the end as their irritability is lowering. They not only need heavy slow, meaning eccentric care to those extensor groups, they also need energy storage and release. So when we talk about fully rehabbing a tendon, you need that piece to do that. And I think we stop short a lot in PT, right? We stop once they're pretty good with these wrist extensions and doing pronation, and then they do some carry drills, and then they do bent over row. We're like, good to go. See you later, Janice. Have a nice life. But we can do better and really incorporate that last final stage when we think about total rehab of a tendon. And we dive deep into this on Sunday at our course. And so if this is sounding unfamiliar to you and you want to know more about tendinopathy, please join us. But the two kind of things that I think about and use when I'm thinking about energy storage and release here, because you don't see this in literature quite yet, is we all have this weighted ball, right? We probably did some ABCs, some circles with it. Maybe we've just used it for our pictures. But this is a place where by the way, I see all these waves. Hello. Where you can use this to really isolate and work on. And for those that are not watching, I recommend taking a watch, not just to listen, but this red weighted ball that's about 3 pounds, starting to work on a little bit of catch and release to work on energy storage, right? And then this would be like kind of the first stage to work on it. And I'm thinking about more like a power dosage. And working on this needs to be a part of care to restore. The other part is we need some weight bearing and loading. I don't want Janice to find out that she's not able to like pull her covers up quickly when she's cold, or when she's pushing herself off of a chair like a month past PT where she's like, oh, I thought this was better, but that didn't feel so good. I want to equip her and rehab her for every situation. And so that includes this. And then doing some kind of weight bearing where we're like in a push-up position and starting to do, you heard the ball drop, where you're starting to do some kind of energy storage and release where you're pushing off from a surface, and maybe it's a clap. And I would start at an elevated surface and then move down to a push-up position, which I'm not going to show you that because that will be chaotic and I'll drop the camera somehow. But this is a piece that I think we're really missing in our care of lateral epicondylgia. So the two top things for energy storage and release when we're thinking about those final rehab stages should be some use of release and catch, local to that lateral extensor group, and then doing some kind of closed kinetic chain plyometric push up with a tap where there's this storage and release and a little bit quicker movement. I'd love to kind of know if you have any other ideas for energy storage and release, but those are kind of my top two that I love. And if you really want to up the ante, add in a metronome, right? Research really leans towards 60 beats per minute, doing a 3-second concentric hold, 4-second eccentric. When we're thinking about motor excitability, that's something you can use a metronome for your eccentrics here when they get into low irritability. And you can even use the metronome when you're thinking about throwing the ball and or that plyometric push up. So I know I'm past my time and I need to be quiet. I'm going to summarize. So for people with lateral epicondylalgia and you're caring for these humans, whether it's you or your patients, respect irritability, right? In your repertoire of care, you need to include the lineup of wrist extension, active supination, eccentric pronation, loaded carries, and bent over row. And then you need to get to that end stage energy storage and release. Thank you for listening today. Happy Clinical Tuesday and February 1st, team.